Well, good afternoon, everyone. I want to welcome you to the monthly Henry Ford Transplant Institute lecture series in transplantation. Today, we are very fortunate to have Dr. Emilio Poggio, who drove from Cleveland Clinic to share with us some thoughts on living donor kidney transplant and the quality of organs and donors. Dr. Poggio is not foreign to some of you. He's a native of Italy, but he moved to Buenos Aires very early in life, and where he did his medical education, and then found that the Midwest town of Cleveland is much nicer to be in there. Studied internal medicine and did a nephrology fellowship, and also went on to do a research fellowship as well. And his interests are both in transplant immunology as well as in organ quality and outcomes and living donation. And we're very happy to have him with us today. And please join me in welcoming Dr. Poggio.
Thank you very much. Okay, thank you all for the invitation. It's a pleasure being here. It was a quick drive, 3 hours, with stop included, so not bad. So I was thinking what to talk about when Anita invited me. I asked her, what do you want me to talk about? And she said, well, whatever you want. So one of the areas I'm interested in is in living donation, and this comes from, as a fellow, I got interested in kidney function measurement, and most of our living donors go through the GFR lab that we have established in nephrology, and I put all the data together, and I found interesting observations that then led me to get more involved with living donors. But at the same time, I was doing a lot of living donor evaluations and transplant recipient evaluations. So what I'm going to talk today is about the quality of the organ in the living donor. We think a lot about quality of organs in deceased donation when we categorize them in standard criteria donor, extended criteria donor, etc., etc. And then we just group all together the living donors all together, thinking that they provide the same type of organ quality. So I'm going to try to discuss what the implications of the, number one, where all living kidney donors are the same, and then how this impacts on the allograft outcome. Most of the research in the area focuses on how this impacts on the living donors themselves after donor nephrectomy. So I'm going to take a little bit of a different view here. So again, when we think about allograft outcomes and allograft loss, most of the focus goes into the immune-mediated mechanisms that lead to graft failure. And if you think about all the money that the NIH allocates to it, 99% goes to study immunology. However, there's a wider range of factors that affect the outcomes of the allograft that they are also important and that we may have an opportunity to minimize. Then I'm going to talk about what we find in the histology of these kidneys at the time of implantation. We believe that living donation is part of, in living donation we are dealing with healthy people, but you will see how many abnormalities you can find in the kidneys of healthy people, basically. And then we look at different metabolic characteristics or different metabolic factors that they may impact on the quality, on the histology of the organs. So as you well know, like I just mentioned, living donation provides much better, this is data from the SRTR database. As we all know, living donation provides much better graft outcomes than deceased donation, especially the ECD kidneys. And as time goes on, grafts are being lost. So while we have pristine organ at the time of donation, by 10 years out, 40–50% of them are not functioning anymore. So, like I just said, everybody thinks about immunological factors. We all worry about donor-specific antibodies, rejection here, rejection there, recurrent disease. But at the same time, we have to think about the non-immunological factors that may have an implication to graft outcome. I have a glass, I'm sorry. I'm being taped. Sorry for that. If you can give me a cap, that would be good. Just to put the water. So if you think about factors affecting the allograft outcomes, like I just said, we have the immune-mediated factors. Thank you. and the non-immune mediated factors. Among the non-immune mediated factors, the most commonly one that we deal with is donor age. Think about the deceased donor. The age of the donor is a key determinant of the quality of the organ that will eventually impact the allograft function. There are others, like ischemia time, or other factors, in this case related to the recipient, but we can also think about these factors in relation to the donor: high blood pressure, diabetes, or glucose metabolism dearrangements, and dyslipidemia that may eventually go into affect the outcome of the allograft. So, like I said, some factors related to the donor, such as age, gender. Here, gender is not about the gender itself, but it's the organ mismatch. One way you can think about it is like organ quality, histology, and then the organ quantity, the nephron load, that will both determine the organ function. So nephron mass, ischemia time, delay graft function, etc. These are all non-immune mediated factors that may have an implication to outcomes. So one of my colleagues now, Jesse Scholl, he's an epidemiologist who used to be at the University of Florida, now he's at the Cleveland Clinic, has published extensively on donor quality in the setting of deceased donation. And this paper, published now 7 years ago, in this paper he looked at how different determinants of organ quality, such as donor age, histology, etc., impact allograft function. This is not surprising, we all know. He categorized them in different grades. Grade 1 being a very pristine kidney, 20-year-old kidney from a 20-year-old donor who died in a motor vehicle accident, no metabolic risk factors, and versus those who will be categorized nowadays as extended criteria donor kidneys. And you can clearly see how, of course, the long-term outcomes, controlling for all the immune-mediated factors that we can control for, like rejection, immunosuppression, etc., will translate in a different outcome for the graft. So there's no way we cannot think about the same way in living donation. Although the spectrum, the range might be different, yet not all kidneys are the same. So if you think about donor quality, what determines the quality of the organ? Donor age, ischemia time, the histology, which might all be related to metabolic features in the donor. And then you think about the quantity of the organ, basically the kidney size or the nephron load that the recipient gets. Between these two factors will determine the function of that kidney, whether it's in the donor or it's in the recipient. It will make to the function of that organ. So I'm going to take this paradigm to try to go over different observations that we find in living donors. And at the end of the day, I'm going to share some data that is not published yet that the fellow is working with me on that is interesting. So I'm going to touch a little bit on the donor age, ischemia times, nephron mass, metabolic conditions, and then renal histology. Age, this is the easy one. There's plenty of data. Initially in deceased donation, now in living donation, coming from many different centers, showing that after you adjust for everything, even in the setting of living donation, this is data from the Mayo Clinic, there is a relationship between donor's age and kidney function in the recipient. This is not surprising. This relationship exists early on, 1 month post-transplantation, and it remains similar a year after, and if you keep moving farther out on time, you find the same relationship. So the age of the donor relates to the quality of the kidney, and this is not surprising. We get older, Kidney function goes lower as we get older, only if you adjust for body surface area. Interestingly enough, if you adjust for metabolic rate, the function of the kidney in each individual remains flat. It's just because as we get older, we have less demand for kidney function because we move less, we have a lower metabolism, etc. So that idea that as we get older, the GFR drops is only if we adjust it for body surface area. But if we adjust it for the activity we do, it's like the muscles. We walk less, we run less, etc. So we need less to maintain the quality of life. But donor age is an important recipient. So this is important because if you think about per-exchange donors, programs, it's not fair to, and it's obvious, to exchange a 30-year-old kidney for a 60-year-old kidney and swap, because then you put in disadvantage one of the pairs. This is just looking at function. Later on, the same group went and looked at the outcomes of these kidneys in relation to graft failure. And as you can see here, this is the same data basically published a few years later. And now, instead of showing GFR on the recipient, they are looking at the graft outcomes. And you can see that if you receive the kidney from an 18 to 30-year-old guy or lady, after you adjust for everything else, you are much more likely to have a better graft survival than if you receive an older kidney. So the next potential insult to the kidney is ischemia times. And like in deceased donation, the longer the ischemia times, the more likely that the patient will develop delayed graft function and perhaps lower kidney function in the long term. There are 2 or 3 studies, one from the Cleveland Clinic, which I'm not going to show because it shows the same thing. But then this one uses data from UNOS. Simpkins, this was published recently in the American Journal of Transplantation, and they look at all living donors across the country, and they divide them based on cold ischemia times of 0 to hours, 2 to 4, 4 to 6, 6 to 8. And this is important in the new approach to exchange programs where kidneys now are shipped far from the institution. In fact, this study comes from Johns Hopkins, where they advocate that. That's why they wanted to show that there was no long-term injury to the kidney. But they look at graft survival, 1-year serum creatinine, delayed graft function, acute rejection as the outcomes of these kidneys based on the cold ischemia times in the setting of living donation. Not surprisingly, like in deceased donation, the longer the ischemia time, the more likely you are to have delayed graft function. It's not quite statistically significant, but there's a trend up. It's not as marked as it is with deceased donation, but there's a trend. However, the important thing is when you look at the kidney function of these recipients, the kidney function in the long term is the same independent of the cold ischemia time. So while the cold ischemia time might delay the recovery of kidney function, and we all know that, and might delay the discharge of the patient by a day or 2, it does not have a tremendous impact in the long term. This is a Kaplan-Meier of the same, so there's no difference in graft survival in the long term depending on the cold ischemia time of the living donor. Well, I'm sorry for this. The table doesn't project very well. But in this study, basically what they did is they look at the effect of warm ischemia time on graft outcome. And once again, you have a little bit more delayed graft function in those patients. Group C is more than 10 minutes, I think, of warm ischemia time. But in the long term, just trust me here, in the long term, there was no difference in regards to graft outcomes or function in regards to warm ischemia time. So in summary, what I said that donor age is important in predicting graft function and graft outcome. Ischemia times, at least what we see in practice now, doesn't have a tremendous impact on it. So the next point I'd like to review is nephron mass. And this is important because since the 1990s we have this, the Brenner hypothesis, in which renal nephron mass is important in determining many outcomes in kidney disease, hypertension, etc. I was a fellow when I, or finishing my fellowship when I did this study, but one of the things that those days we were beginning to study the anatomy of the kidney by 3D CT scans, and I remember Stanford were doing MRIs, and a few centers were also doing MRIs, but most of the centers, I think, they were doing 3D CT scans. So I took to radiology and they calculated the kidney volumes. And the first thing I wanted to know was whether the size of the kidney related to the kidney function based on GFR. And obviously the larger your kidney and adjusted for body surface area, the larger the kidney, the higher the absolute GFR. So that was important because if you get a very large kidney and you transplant it to a very tiny lady, then you would expect, if you adjust the kidney size to the recipient body surface area, you would expect that that patient will have a much better graft function than the opposite. So we look at that, and this is here you have GFR on the y-axis, and then you have 3 plots. This is kidney volume, more than 120 cubic centimeter per meter square, per 1.73 meters square of the recipient. Here we have age of the donor, more than 25 years old, and then GFR, this is GFR and this is age. And as you can see here very clearly, those recipients receiving a large kidney in relation to their body surface area have a much better kidney function than those recipients who receive a small kidney. Same thing in regards to the GFR, although they are very related. And then same thing if you look at the donor age. So if you think about a swap, an exchange between, other than the immunological issues like we discussed today, HLA matching, etc. If you now get a kidney from a 65-year-old lady who has small kidney, and you give it to a 30-year-old young kid who has a BMI of, let's say, 28, then it is likely that that patient will have a creatinine that's never going to go below, let's say, 1.4 or 1.3. So the expectations can be better set or can be better presented to the recipient when you have these size and age mismatches in between it. Well, basically this, I'm sorry for this figure. This is just data. I just put a graph together for the NIH and to show that relationship, the amount, these are different quartiles of the size of the kidney, and this is GFR on the recipient. As you can see, the more kidney you get, the higher the GFR. So one of the problems with this was that at the Cleveland Clinic, I published this with a radiologist, and then after this paper, he decided to report the kidney volumes on every single CT scan. So now the surgeons are, why, they're trying to take a kidney, the other one, they look at the volume, we don't know what to do with the information, everything. It was just, I wanted to show an association, but it turned out to be, now they reported on the CT report. Well, we were not the only ones. There are many groups that they showed this. This is another group that they do a lot of living donation in Korea, and also here from the University of Michigan, Dr. Pelletier. And they also show the same relationship. They look at the graft weight. They took the kidney, they weighed it before they put it into the recipient, and then they adjusted it for the recipient weight. And you can actually find the same association between graft size and kidney function in the recipient. So, kind of like a little summary here: nephron mass and donor kidney size and recipient weight or recipient size impacts allograft function in these patients. Now, does it really matter to have a creatinine of 1.3 or 1.7? The point is that the patient is off dialysis, the patient is doing well, asymptomatic, nobody feels anything with a creatinine of 1.7 or 1.3 or 1.1 or 0.8. If you really go by if you believe the epidemiological data published in several situations, but the first one was, I think, by Harry Haran in Kidney International in 2002, where they look at UNOS data. And they simply look at the serum creatinine that you get at 6 months, 12 months, and the delta between 6 and 12 months. And they control for everything else. And you only use those factors to determine long-term outcomes. And there's definitely a clear association between serum creatinine at 6 months or 3 months, whatever you want to choose, the baseline serum creatinine, the nadir serum creatinine, and long-term graft survival. So while these studies are all short-term, 1 or 2 years. We are using serum creatinine as a surrogate marker for graft survival, and we believe that this eventually will translate into poor outcomes. So let's talk a little about donor metabolic conditions, and this came up today in the second case that it was presented, because this is a very different time for living donation. It used to be 30 years ago. So metabolic syndrome is a constellation of comorbidities with negative implications to the cardiovascular health. Abdominal obesity, dyslipidemia, hypertension, hypertriglyceridemia, etc. It is associated with chronic kidney disease, and it increases the propensity to acute kidney injury. And then metabolic features in living kidney donors may confer a risk to health of the donor organ, and therefore they might increase the possibility of future allograft dysfunction. I don't have the data here, but one of the things I looked into, which we published in Kidney International in 2009, was at the living donors from the 1970s. So the Cleveland Clinic has established a kidney function lab in nephrology, a GFR lab, in 1960s. And then this lab was the one that was used by the NIH for all the NIH-sponsored studies, the MDRD, the CRIC, the ASK, all these studies. So all these GFRs were done in our department, right by our offices and where we see patients. And because the lab was there, every single living donor since the 1960s went through the lab and got a GFR done. So we have records since 1972 in paper, and when I was a fellow, I put them all in an electronic format, 20,000 GFRs, of which 1,500 were from living donors. From those 1,500 GFRs since 1970s to now, 300 of them never donated because the donor has some issues. 100 of them didn't donate because the recipient found another organ or something happened, but the donor was approved. And then 1,100 donors went on to donate the kidney. And there are three things that came up easy observable. One is donors get old. They've been getting older since, or we are accepting them at an older age since the 1970s. That's not surprising. They're getting heavier, 1 kilogram per meter square heavier every decade. We move on. And the GFR has been declining by about 2 mL per minute per decade of measurement. So no doubt that the criteria for accepting donors nowadays is much less stringent than what it used to be in the 1970s, when the true healthy people donated kidneys. And all the long-term outcomes that we see nowadays reflect those donors, not the ones that we are using now, but the ones that donated 1970s, 60s, 70s already. The paper from Minnesota by Hassan Ibrahim used donors from 1960s and 1970s. So metabolic syndrome is something new, not only to the living donation, but to everything in medicine. So in fact, one of the fellows working with me a few years ago, now he's staff at the University of Minnesota, we look at different of these factors that they are part of the metabolic syndrome. Metabolic syndrome is composed by hypertension, high triglycerides, low HDL, high glucose, and high BMI or weight. And as you can see here, the GFR of the recipients receiving kidneys from donors who were young versus old had a different GFR. This is in univariable analysis. Those who got a kidney from a donor with higher GFR by iothalamate had a much higher GFR than those who received a kidney from a donor with a lower GFR. This is unadjusted. Then kidneys, recipients who receive a kidney from donors with a blood pressure less than 120 had kidney function much higher than those recipients who received a kidney from donors with a blood pressure of more than 120, but less than 140. They are not hypertensive, they are pre-hypertensive. They have a blood pressure between 120 and 180 in the clinic, not even ambulatory blood pressure measurements. And then if they have high cholesterol, the donor had high cholesterol, the recipients also had a lower kidney function. So when you put everything together, in a multivariable model, I don't have the data here, these factors remain independently associated with graft outcome. And if you see here, if the donor had none of those factors, was a young guy with no cholesterol, normal blood pressure, etc., the recipient had a very high GFR. If the recipient received an organ from a donor who was more than 45-year-old or older than 45, low GFR, a high cholesterol and blood pressure more than 120, that recipient had a much lower GFR, and this is adjusted for all the recipient factors. So no doubt that you can still try to. So there's no doubt that all these metabolic factors will have an impact on the quality of the organ that we accept for donation and that we transplant. And again, I want to make the point, not because of this, you're going to preclude donation in this setting, but it's good to know the information so you can advise the patient accordingly and then set the right expectations. This kidney might not lead to a creatinine of 0.8, but if the creatinine nadir is 1.8 or 1.4, then you know why. So let's look at the histology of the kidneys. It was also always believed that in the setting of living donation, the priority is not to harm. So you will only remove a kidney from someone in which you can secure the long-term health of that donor. In order to do that, you have to assume that you have normal kidney function, and you have to assume that you have normal histology. So, since we do implant biopsy since 2000, a lot of programs do it. We've learned a lot about this. A lot of these kidneys are not truly healthy kidneys, and you find a lot of stuff in it. So you can find acute changes, and you can find chronic changes, most likely chronic changes. Would they affect outcome, the graft outcome? This is one of the best studies, the best study that addresses this. This is a study by Andrew Rule and the Mayo Clinic group, in which they look at their implant biopsies of all their patients since 2000, 1,200 donors. Here you have donors with hypertension, with BMI more than 35, every single type of donor you can imagine. They did corneal biopsy, and they look at the histological findings, and they look at interstitial fibrosis, tubular atrophy, arteriosclerosis, glomerular sclerosis, and if they had two or more, they call it nephrosclerosis. I don't know what happened there. The first observation is that as we get older, you don't see it here, I cut the top of the table by mistake. Patients have more, not surprisingly, more hypertension, they are heavier, more cholesterol, everything that we get as we get older. The very interesting thing is, I'm sorry for this, you have to believe me here, as we get older, we go from having a pristine kidney when we are at the age of 30, up to 30. Only 3% of the patients, the donors, had some sort of glomerular sclerosis, nephrosclerosis. But as you get older, if you get a kidney from a 50-year-old lady, you have 50% chances, or men, 50% chance of getting a kidney in which you can show nephrosclerosis in the biopsy. So to start with, in living donation, it's more likely that you are going to get, or it's quite likely you're going to get a kidney with abnormal histology to start with than what we thought 20 years ago or 30 years ago. I'm not saying this is right or this is wrong. It's fine. It's just I'm trying to, as we practice new medicine, we learn a lot of things. And as long as we acknowledge what we have, then we can understand the limitations and the potential implications to it. Maybe nothing happens. Maybe it's likely that most of these donors outlive their kidneys, therefore they die of something else before they have any problems with the kidney. But the point is that not all living donors nowadays are pristine kidney that you say you should expect a creatinine of 1 no matter what you do. And again, I'm not saying that's something new, but I'm trying to show the data. Same thing, they look at these kidneys, and now with the abnormal histology, and they want to look at the outcome of the recipients. So now you see here that from all the donor variables, if the donor had, this is interstitial fibrosis or no interstitial fibrosis or interstitial fibrosis. From all the abnormalities you can see in the implant biopsy, those recipients that received the kidney with interstitial fibrosis, at least 5%, they had a match. So the GFR in the donor was no different. It was a little bit lower. No, it was not even lower. It was the same. So you cannot pick it up clinically. You need an implant biopsy to know who has glomerulosclerosis. Those with glomerulosclerosis or nephrosclerosis won't have a lower GFR. However, as time goes on, you can see how the GFR of the recipient of those kidneys starts to drop while the other one is maintained. So recently, looking at the patients, we report the implant biopsy on the recipient chart. So somehow, and we do protocol biopsy. So I went back to look at the implant biopsy because it's good to know what the implant biopsy shows in order to understand what the protocol biopsy or any subsequent biopsy looks like. And I found that a few of these patients had ATN-like changes in the biopsy. Not surprising, the kidney is under ischemia time for like some time. So it's not surprising to see that you can have some acute ATN. In fact, if you think about delayed graft function in the center of living donation, about 5% of the donors, of the recipients, will have delayed graft function. If you look at SRTR data, I don't know, at the clinical it's 4.9%, which is very similar to what is shown across the nation. So we said, well, why don't we go ahead and look at Tolle Fellows to see how many of our donors had ATN at the time of the implant biopsy. And let's see how many of them had chronic changes, and let's see if those who have chronic changes are more propense to having ATN or vice versa. And how does ATN, or how can ATN affect graft outcome? Maybe it doesn't have much impact. So the first question was, does ATN type changes happen at time of organ harvest in living donation, at time of implantation? And ATN type changes are mitotic figures or vacuolization of the cells or typical ATN in the histology. So we have different questions. How often does it happen? What's the prevalence of the disease? What determines ATN? What are the donor factors that predispose the patient to develop ATN? Is there any surgical factors like ischemia times? Although I show you data that ischemia times don't have any impact on, minimal impact on delayed graft function and nothing in the long term. Is there any other histological finding associated with ATN? Or what are the clinical implications of ATN? Do we need to worry about it? Does it really matter? You know. So we set a few goals, and again, to study the prevalence of these diseases, to study the implications of these abnormalities on the allograft outcomes, and to study the donor characteristics of these patients. So we took about live donors from 2005 to 2011, which were about 324. Actually, there were more, but these are all the patients in which we had all the information. Not only the implant biopsy, but also CT scans, GFRs, normal urine analysis, and everything. We do iothalamic GFR, the biochemical profile, the fasting lipids, glucose, etc., because we wanted to categorize them based on metabolic syndrome or no metabolic syndrome. And then we look at post-donation GFR. We have iothalamic GFR, but also estimated GFR, and it's the same thing. It doesn't really matter. You don't care about the few mLs per minute difference here. You look at the trends over time. And then we define metabolic syndrome using one of the definitions. And metabolic syndrome is defined as having three of the or more of the following: fasting glucose more than 100 or abnormal. I don't know what your lab reports here. I think it's 105 based on what we talked today. Independent of the oral glucose tolerance test, which can be normal, but glucose intolerance, 25% or 30% of the patients with glucose intolerance will eventually end up developing diabetes or some sort of diabetes. So that's what the definition uses is glucose, fasting glucose. HDL less than 40 or less than 50 for females. High triglycerides, this is 250, not 150. And blood pressure, more than 130/85. So be aware here, this is pre-hypertension. Hypertension, normal blood pressure is up to 120. And we often see this, and then a BMI more than 25, which is very easy to get. The definition calls for a BMI more than 30, but we lower it to 25 because of most of the living donors tend to be much thinner, and then you don't get many patients there. So, from these donors, about 12% had metabolic syndrome. Not many. I thought I was going to find more. Many have one or two features, but three or more features. It's not bad. Midwest, this is very consistent with data from other centers from the Midwest. Our mean BMI for the donors is 28, which is pretty much the same as the one reported by Mayo Clinic, and I'm sure it's about the same across the Midwest. We have about 60% more male than female have metabolic syndrome. Very few African Americans have metabolic syndrome because we tend to be much more strict with regards to blood pressure and weight for selecting them. So sometimes we put them on products to lower. We are more strict with the blood pressure. The BMI here is 29. It's much higher, but it's part of the definition in those with metabolic syndrome. Otherwise, pretty fit population. Systolic blood pressure, of course, is much higher. Diastolic blood pressure is much higher. So it's a quite identifiable population. The GFR is lower. The creatinine is higher too, because they tend to be bigger people. They have no more microalbuminuria, which is good to see. They have a higher, of course, fasting glucose. They all have a lot of them, 30% of them have hyperuricemia, which is another marker of metabolic syndrome. So you can identify them. It's not. I thought it was going to be more patients, 12%, 15%. I think it's not bad. The ischemia times, and then I will show them to you based on our thing. But the ischemia times, these are ischemia times for the whole cohort. I don't know. I'm not a surgeon, so I don't know if it's good or not. But warm ischemia time is about 4 minutes. Cold ischemia time a little bit longer, quite longer. The total time is 131 to do the whole surgery, I guess. 15% of all these patients had ATN in the biopsy. 12% had glomerulosclerosis. 22% arteriosclerosis. This is the whole group. 7% IFTA, and about 40% only had a pristine kidney. Everybody else, the other 60% had one thing or the other, but it was not a totally clean kidney. So these, I think, are the donors from the 1960s or 70s, where they have no metabolic syndrome, pristine kidney, healthy. Now it's only 40%. Everybody else have something that you can find. Okay, and then if you look at the histological abnormalities, either glomerulosclerosis, IFTA, or arteriosclerosis, none, 1, 2, or 3 findings, you can see that those patients with metabolic syndrome are much less likely to have a total normal kidney. Okay, well, in this group you have almost 80 or 90% of the patients with one or less abnormality. In this group, you only have 30% of the patient in which you have much lower. It's not that much more, but it is statistically significant. This is a small cohort. So that's it. What's the impact on the kidney function? So the first simple divisions here, we divide those patients in which you had found ATN in the implant biopsy versus those in which you didn't find ATN. And the GFR at 1 year is much lower in those patients in which you find ATN in the biopsy. And if you divide the GFR of the recipient based on GFR less or more than 45, you have the same observation. Now, that doesn't tell you anything, because maybe ATN is associated with chronic changes, maybe ATN is associated with older age, maybe. So we went further and look at what other associations you find to see if ATN truly has any effect, because I told you that ischemia time leads to a little bit of delayed graft function but doesn't have any implications in the long term. So, interesting enough, and again, this is actually in nephrology, in any primary renal disease, the most predictive finding in the histology of the renal biopsies is interstitial fibrosis. So if you have IgA nephropathy, FSGS, whatever, what determines or what's associated with the chance of developing end-stage renal disease is interstitial fibrosis, is not glomerulosclerosis, and is not atherosclerosis. And here is the same thing. If you look at the graft of the recipients who received the kidney with interstitial fibrosis versus those who didn't have any interstitial fibrosis, the GFR is much lower in those kidneys where you have fibrosis. And in fact, as we all know, in transplantation itself, IFTA is the most important marker of graft function independent of whether it's a living donation or deceased donation. But then when you look at, I'm sorry for the scale is wrong, but when you look at atherosclerosis or glomerulosclerosis, it doesn't really matter if the donor had any of those findings in relation to the GFR of the recipient. In a multivariable analysis, having a no implant biopsy and no rejection, and I didn't put it here, but a normal kidney determines graft, it's associated with graft function. Also, the most important driver of graft function are age and the renal mass, rather than all the stuff I'm talking about. So getting a large kidney from a young, healthy donor, large donor, is the best thing, as we all know, not only in deceased donation, but in living donation too. Renal mass and a healthy kidney is the best thing you get. So then we thought, well, maybe if it's not associated, what's that association? Maybe it's metabolic syndrome associated with hypertension, and then we have an opportunity to tell them to change their lifestyle so we can minimize this. And indeed, if you look at those patients in which metabolic syndrome was diagnosed, 20% of them had ATN type changes versus only 10%. So most of the patients in which ATN was found, they have metabolic syndrome. So the next question is, well, maybe because of their increasing size, the ischemia times are high, and therefore you can see the ATN. So we want to look at all the ischemia times, warm ischemia time, cold ischemia time, revascularization time, and total time. And this is looking at the relationship between ATN, and we didn't find any association between ischemia times and ATN. So even if the patients are larger, the surgeons manage to roughly operate with the same time frame in all these kidneys. So then what could it be? Well, I don't know if I show it to you, but one of the most important associations between ATN and Kosovo it was with chronic histological changes. So this concept was published, I think, by Hansiker back in the mid-1990s. There are two things when you look at the function of the kidney, transplanted kidney, and how you can put this into context. One thing is your intercept. What's your baseline creatinine? What's your nadir creatinine? And the next thing is the slope of the creatinine, how fast it's going to decline. You have an opportunity to set this high by either selecting the best kidney you can for your recipient, understanding that some recipients might need to take a bad kidney because they've been waiting on dialysis for like 5 years and they're sensitized, and this is the only kidney we can give them. But also understanding that if they have an opportunity to get a good kidney, it will determine their nadir serum creatinine. And while this is an obvious concept, I think now we have more information and we can at least provide the the background to support that notion that low creatinine post donation is the first step in achieving long-term outcome. The next one is to maintain the slope, to keep it steady, and then this is more immune-mediated, trying to prevent rejection, minimize nephrotoxicity, minimize other things. So organ quality and quantity might play a role in setting up at least the initial graft function. Getting a large kidney from a healthy donor, we all know is the best thing. And again, I think this is very important because now we are doing a lot of pair exchange programs, and we think we did like 5 or 6 already this year at the Cleveland Clinic. So if you're going to swap your kidney, you want to make sure that the kidney that comes to the person that you would otherwise donate is of roughly similar quality. You cannot quantify everything, but you don't want to take a kidney that is coming from a very tiny person who is older in age and who is obese or overweight. So I think the quality, or what I call the quality, but the histology of the living donor organs is quite heterogeneous, and we know that now. And this relates to allograft outcomes. The organ quantity, or the nephron mass, is also heterogeneous and relates to outcomes. And when we look at these, now that you can roughly estimate the volume of the kidneys, you can easily see the variation in size, not only in gender. Age actually doesn't really affect the size too much. It is believed that aging shrinks the kidney a little bit because of more glomerulosclerosis in the long term. But gender, of course, ladies have, smaller bodies have smaller kidneys because they need, the kidneys are, the size is according to the needs of the subject. But the size is also heterogeneous. Both determine organ function, not only the quality or the quantity alone, but both combined. And while these factors do not preclude consideration for living donation, they should be kept in mind when advising patients on unexpected outcomes, or for example, in pair exchange programs. We have now with Andrew Root from Mayo Clinic and me, we have a grant from the NIH, from the NIDDK to study, to combine the Cleveland Clinic and the Mayo Clinic database. I was saying today, we're going to get all the implant biopsies from 2000 to now. All the CT scans will be reread by a central lab, and all the GFRs combined in a database. So I think we'll have about 2,500 living donors with all that information. And I think we're going to learn quite a bit on the aging process in the kidney, the factors that affect kidney health, and in a cohort of them we will have follow-up, and we will be able to see if this really matters to the donor, which I didn't talk today. It's a totally different talk. And again, I want to reemphasize here, the recipient takes whatever he can take, because it's better than being on dialysis. But these are things to keep in mind when we talk to the patients. And this is it. Please give me send me an email if you have any questions or anything, and I'll take any questions.
Thank you, Dr. Poggio. This is a very intriguing presentation. When I look at liver transplants and I put in a fatty liver in the recipient without metabolic syndrome, it seems like those recipients lose fat in the liver, and the liver gets better, and the reverse happens too.
Yeah.
And I wonder if you get a kidney that has the issues that you mentioned with fibrosis, interstitial fibrosis, or a healthy kidney.
Yeah.
How did the profile of the recipient impact the outcome on that kidney?
Yeah. So I want to say two things. One is about the fatty liver. It's an amazing thing. The other thing I found in one of these CT scans one day, I was looking at doing the donor evaluation, reviewing the data before we present to the committee, and I look at the CT scan, and it was a patient with a donor with metabolic syndrome, or a little bit obese. I don't remember if he had metabolic syndrome or whatever, but he had fatty liver. So then I asked Brian Hertz, who is said, in the next 2 months, count how many have fatty liver. He came with 3 or 4. Fatty liver is a disease of nowadays too, with increased BMI and everything is what you get, fatty liver and then NASH and all the stuff. So fatty liver, in contrast to interstitial fibrosis, the kidney doesn't regenerate, but the liver there's an opportunity, a window of opportunity in the liver before the liver goes cirrhotic to change that pattern. And I think in living donors, we are following them under a program called WIN program, or I can't remember what it means. Wellness in, I can't remember the end. But regardless, we follow the donors very closely, and we offer them a free wellness program. And interesting enough, number one, everybody takes it because it's for free. And it's usually under the executive department, whatever they call it, the clinic, where you need to pay to get it, but the donors have free access to it. So they get all the stuff. And one of the most interesting things is a lot of the donors lose weight. And I don't know if the fatty liver goes away or not, but they are so motivated and they are so excited about being, and this is only 6 months, 1 year. I don't know what happens 3 years from now, but they lose weight, and I hope that their fatty liver goes away and all that stuff. Actually, about 50% of the donors who had a high BMI went into normal BMI after donating the kidney. And interesting enough, 15% of those who didn't have metabolic syndrome before, they develop metabolic syndrome within 6 months of donating, because I don't think we emphasize to them, because they're already fit, we don't tell them anything, and then they gain weight. But so that's one thing about the interstitial fibrosis. I don't know if you can reverse that, but you can reverse everything else, and you can prevent further, damage to the kidney by changing metabolic risk factors. And in fact, that's what's going to kill them, cardiovascular event. And metabolic syndrome is just was made by the cardiologist to prevent, So the other thing is the kidney volume. There's actually very nice data from the Koreans, that they do all these living donors because they cannot do many deceased donors. So they do a lot of work in which they measure kidney volume, kidney function before and after. And the kidney get adjusted to the size of the recipient, and it hypertrophies to the point that is directly related to the size of the recipient. And the kidney function, they look at these very pristine patients in which the creatinine was perfect. So the kidney seems to shape up to the new, in relation to the size of the recipient because of hyperfiltration and everything, and then it accommodates. But what is irreversible in the kidney is fibrosis. Yes?
Two quick questions. One, how did you account for sampling errors of all the biopsies and wait and put on them by taking 2 biopsies? Or do you just do it because you just took a very large N, and so any biopsy that was maybe a sampling error just got washed out in the 1500?
We have, going through the process of putting all this data together for this NIH grant that we have, we look at indeed, there's a problem with sampling error. It's no more than 5%. From 102 biopsies that we just did a few weeks ago, in 4 or 5 we didn't have enough glomeruli to do a proper, you need to have 10 at least in order for the pathologist to call the sample appropriate. So you do have sampling error, and sometimes you get medulla alone or whatever. So that's not statistically accounted for, and that's a very good point, because you might not have enough tissue.
One other question. In terms of the patients who had the metabolic factors, whether it's metabolic syndrome or not, that attributed to maybe some of the negative things that can happen in the liver function of the recipient, what about the patients, do you have patients who you've asked to modify their lifestyle, who may have had metabolic syndrome factors, that got better, at least by the lab values, and then donated?
Yes.
So shouldn't there probably be chronic and permanent in the kidney? So I would expect it to be the same, but what was your experience?
Yeah, no, but I think the important is the attitude. The important part is the attitude. Even if they have chronic changes, the fact that they show that they can lose weight and change their lifestyle is a very important thing.
No, but did those recipients who received those
kidneys, I don't know. I didn't look into that. But that's a very good point. Because we can identify easily to whom we say 3 more months or 6 more months or lose weight to this point, etc., and see how they are. That's a very good point to look at. Whether modifying factors really eventually have translated into the. See, here you have to think about the donor and the recipient. So about the donor, yes, you want them to change their attitude. About the recipient, that's a very good point. Yeah.
That was a great talk. And one of the things that we try to face here in Detroit, of course, in the Cleveland Clinic data, the Mayo data is very homogeneous for the most part.
Yeah.
The percentage of African Americans is less than 10% of the whole population of living donors, where ours is like 30 or 40 easily. And as you look through the data here, just using the white Caucasian population base for the most part, you see that interstitial fibrosis, metabolic syndrome, all these things are compounding factors negatively on the kidney function or recipient function. In the African American population base, the thought is that you may possibly compound that if you have more than one. I think most people look at hypertension and say that's a cutoff of why you don't take African American donors. But we don't look at HDL,
everything
we don't
else.
look at triglycerides, we don't look at interstitial fibrosis nearly as much. And the question is, if you actually do look at that, you say, maybe we shouldn't transplant those patients because the outcome may be significantly worse, where it will affect both the donor, for one, and the recipient long term as well.
So I look at, so we have about 15% of the donors are African American. Well, in this data, when I look at the 1,001, this is because it is a small cohort of the whole thing. But when I look at the whole thing, one of the first things I look into it was a kidney function, for example. There's absolutely no difference between the kidney function of Africa. A lot of things are blamed to the race, and it's more sociocultural than. And there's many factors that they are implicated into it. Same thing like today. We're talking. Why do we give thymoglobulin to African American patients? Well, they are higher risk. Why are they higher risk? So there are many questions, and if you look at immunologically, everybody's blamed. Yeah, they are blamed to be a higher risk. But the immune system reacts to the antigen to the same way. It's the conditions that led the patient to become higher risk. And when we look at a paper published by George Augustine, who trained with me, and he's at the University Hospital with Don Reisig and me and Peter, on the immune reactivity to common HLA antigens at the cellular level in dialysis patients who were white versus black, we couldn't find any difference in vitro assays or in vivo assays to show that African Americans are indeed different in the way they react to antigens. Now they are more exposed to HLA antigens, which makes them more propense. So when I look at kidney function, for example, you look at creatinine, and there's a difference between creatinine for the same GFR in African American versus non-African American. You look at weight and you look at NIH, in Haynes data, and there's tons of differences. But when you look, for example, at very well measured things like isothermic GFR, I could never find a difference in GFR, for example. There's a paper now that just came out on this, what's the name of this gene that is associated with FSGS in African Americans? APOL. So they thought, well, here we are, it's associated with more FSGS. Let's go and check it in transplant recipients and see what the outcome is. Nothing. So sometimes, it's true, we don't have many African American people in this cohort. But when we put everything together, I hope to have enough number and see if there's any true difference between hypertriglyceridemia and histology and this and that. Now, they might be more overweight, but we screen them out because we don't let them donate. Now, there's one thing about hypertension in African Americans. If you think about, a lot of the times we just call, and I'm a nephrologist, but I'm not a very good, I don't read too much the nephrology literature, but I learned something from my former chairman. And I read the paper. And a lot of the times we blame end-stage renal disease to hypertension, especially in African Americans. In dialysis, 30-40% of the patients have hypertension / unknown as a cause of kidney disease. And we think the hypertension causes kidney disease. And there's no data to show in humans, in Caucasians, that hypertension initiates kidney disease. It makes progression of kidney disease faster. That's why you have to control it. But the data do suggest from the Mr. Fit study, one study from the 1980s, that hypertension on its own can initiate chronic kidney disease in African Americans, but it was not shown to initiate kidney disease in non-African Americans. That's the only data I know about hypertension in African Americans or kidney disease, So I don't know the histology in African Americans, but we'll look at it.
I'm curious, because then where you make comment is that we're negatively biasing against African American donors.
Yes, we because.
That now it's hypertension will turn them down.
Yes.
May not have as much interest.
But that's at least there's a basis. You know, hypertension does initiate, at least from that study, kidney disease in African Americans. Now this is a study from 1980s. Who knows if it's a well done? You know, it's a Mr. Fit study. But yes, we screen them, and do we know? You know, we know quite a few things about African Americans. Like they are only 15% of the donor pool, but they represent 40-50% of the patients in dialysis of the donors who donated the kidney, and they ended up on dialysis, 40-50%.
Question in regard to choosing your perfect donor. Would you rather have a high volume recipient ratio versus age? Would you take a younger age with a lower volume to recipient weight, or a older donor with a better ratio?
I like the volume better.
Is it better that the volume?
No, I think usually the problem is it goes together.
Because sometimes you have a young female donating to a large male that is young, and then you like to give how about that?
Well, the young kidney is always good. You know, this is like the engine of a car with 20,000 miles or 70,000 miles. You know, you can think about donor age in the same, you know, using the same analogy. Or you can use the same engine where you want 8 cylinders or 6 cylinders, you know, half of it. You know, it all depends what you want. I think if you have healthy kidney, renal mass determines the long-term outcome of the recipient and the donor. And we have data on the donors that, in fact, we just submitted a paper. We look at the kidney function of the donor after they donated the kidney, and whether they retain the large kidney or the small kidney. And we adjusted for the body surface area of the donor. So interesting enough, if you think about donor nephrectomy back in the 1980s, 60% of them were left and 40% of them were right on the open times. Okay, so now laparoscopically driven laparoscopic nephrectomy led the practice to remove the left kidney based on UNOS data 90% of the time versus only 10% of the time. At the same time, if you think about the size of the kidneys, the right kidney is not the same as the left kidney. The right kidney is chubby and short because underneath the liver, the left is the big one. So we did the study, and actually the left kidney is larger than the right to about 10-20%, but most of the time the left kidney is removed. So you're leaving the donor with a small kidney. It's okay, they live okay. But the point is that when the right kidney was much smaller than the left, and the recipient kept the right, or vice versa, if they remove the right, but the left was the small one, the post-donation kidney function is lower in the donor. So I think, and we use that for the preliminary data for this NIH grant that's going to be reviewed on Thursday. So that, I think the donor size, organ size, in the donor or in the recipient is important. Now, a lot of the times, and the reason we could do that analysis because a lot of the times the surgeons go for the open because the anatomy is too complex. You know, guys, this better than me. They have like 5 arteries, whatever you have, you cannot do it laparoscopically, so they leave either the small kidney or the big kidney because of the anatomy, not because of the anything else. And then, so kidney size in the donor and the recipient, I think is a very important thing. And if you go back and look at all the data associated with low birth weight and kidney size, with hypertension, mortality, and everything, it all leads to the same thing. The more developed the kidney, the larger the kidney size, the least likely to develop hypertension, to die of coronary disease, to have a higher GFR, etc.
That's sized by three-dimensional volume calculations, not just 9x7.
Yeah, but whatever, independent of the way you want to measure it, what I'm saying is, if you have, kidney mass as a concept, I think it's a good stuff.
I have 2 questions.
Yeah.
Number one, I still can't figure around how the interstitial fibrosis and tubular atrophy, and determining that was the factor that was associated with the outcomes. Because in the glomerular literature, it's the glomerular disease determines again, it's all vascular, mostly vascular, and so the petrolar capillaries are disappearing. Because of that, there is interstitial fibrosis and tubular atrophy. To me, I look at glomerular, not the glomerular sclerosis, but arteriolosclerosis as the initial damage, because from arteriolosclerosis, then you have decreased the flow to the glomerulus, petrolar capillaries, and the interstitial fibrosis and tubular atrophy. To me, technically, if I look at it, I think about arteriolosclerosis as the initial point for increase in the IFTA that even in the normal donors that we could have found.
I don't know.
I'm a little surprised at the
I don't know.
here.
I don't know that.
Because,
I don't know if I agree with you. Because if you look at patients with IgA nephropathy, which tend to be younger people, and you look at the most predicting factor in the histology that will lead to end-stage renal disease, interstitial fibrosis, they don't have atherosclerosis. They're young, they're 30, 35.
But they have glomerular disease.
They don't have glomerular sclerosis either.
But again, IgA nephropathy is not glomerular disease. And it's, again, it's the glomerular, the tuft, the disease of the tuft.
Yeah.
And so the post-glomerular, again, the vasculature is reduced and the petrolar capillaries are reduced or disappearing. And that determines the IFTA.
Yeah, well, I'm not good in histology, but...
so I'm a little surprised that GS,
But if you think about transplantation, it's all about IFTA. If you think chronic allograft nephropathy or whatever. If you think about, again, associations between GN and end-stage renal disease, a lot is about IFTA. Now, I think all these metabolic disarrangements lead to microvascular disease, that you cannot measure with the histology. You have to go beyond histology. This lipidemia, what do they all... You have microvascular disease, high glucose, high cholesterol, high blood pressure, everything. And what initiates interstitial fibrosis? I don't know if it's the irrigation to the tubules themselves, or is it decreasing glomerular filtration that leads to the... I don't know. I should talk to... I don't know. But interstitial fibrosis and tubular atrophy is a marker of poor outcome.
And so therefore, when a kidney is offered to us, then what do they give us? They just give us a frozen section. In the frozen section, it's not very easy to determine how much of the frozen section is...
Yeah, you look at glomerular sclerosis and everything. I'm not saying that glomerular sclerosis doesn't mean anything. It does mean, of course, if you got 40%, 30% or whatever. This is actually very subtle changes, less than 5%. So you're talking about you need a very large volume to look at to see differences. But the Mayo Clinic looked at 1,200 people. They didn't find any association between glomerular sclerosis, GFR, with anything. It was all interstitial fibrosis. Yeah.
Hi. I really enjoyed your talk. I just have two sort of related topics and relatively simple questions. One is, I really think that protocol biopsies are very important for all the transplantations. Who pays for the protocol biopsies after the initial, post-implantation biopsy? You can get, the first year, the second year, the fifth year. Who pays for those biopsies?
Well, it's only the first, we do it between 3 and 6 months. That's out of the 3 months, I think. If you have them as part of your standard of care practice, then they pay for it. Yeah. Not all the insurances pay for it. Now, we do it ourselves. We minimize every single cost. We have, I see patients there, the surgeon sees patients there, my office is here, the surgeon's office is there, the biopsy suite is right there, the infusion suite is right there. So we are all within, I don't walk more than 20 minutes to go anywhere. So when you have the whole, like the GFR lab is there, when we see the donor, it's like next door. So when you minimize, the Cleveland Clinic is good at one thing, administration. And they figure out everything. So they figure it out, because otherwise we wouldn't be doing it, believe me. So we minimize, we don't pay the radiologist for anything, we don't pay anybody. We just pay the pathologist to read it. and we have a very limited readout. So it's not a very, you know, we don't do EMs or any fancy thing. You just get, and then if you find something, we dig deeper. But then you have a cost, and then you can justify more. So we set it up, and it's working. I mean, there are many centers now doing it. Emory, Mayo Clinic, Cleveland Clinic, Mount Sinai, Brigham, Northwestern University. I think more and more centers are doing it as standard of care now. More and more centers. There might be at least 20 more. There might be 30 centers that they do it now. The question is the frequency and what do you do with information. That's a big. I think that's more of a problem.
And that's my follow-up question. We were actually looking into doing it as a standard practice, like to get to review this. But my follow-up question was really, if you do find something in protocol labs, say 1 year, say that you find a bad 1A injection, patient's creatinine 1, 1A, patient's doing fine otherwise, would you treat that patient?
Yeah. So, oh, by the way, one more thing I want to say. We also do the ultrasound and everything. So any billing or anything comes through nephrology or urology. Okay. So again, we minimize every single thing. So I don't think that's a problem. The problem that I faced, so the information that you get is very valuable. And like I was saying today, for me and to the patient, having a normal kidney is very valuable information too, because you can reassure the patient, you can redirect your immunosuppression, you can do a lot of things. The most challenging part comes in this so-called borderline rejection. If you look at the data with the subclinical rejection, the tendency is to go ahead and treat even if the creatinine hasn't changed. And if you look at the data from David Rush back in 1990s on cyclosporine-based regimen, it really helped. In 2000, with tacrolimus MMS CellCept, it's less likely that you get a benefit from treating, but yet it doesn't really hurt much to give IVMP or whatever, or oral pulse steroids. We don't know if it makes a difference or not. So the main challenge is the borderline thing, but I think Banff is thinking about removing that category out of the classification, so we will not deal with that anymore. And then having being able to tell the patient that everything is going fine or not, or everything, I think sometimes is good. I don't know, it's debatable. But if you figure it out, it works well.
Any other questions?
One small.
Yeah.
Yes, please.
Back to the question of size and volume of the kidney.
Yeah.
Small size is bad, but young kidneys are good.
It's not bad. It's not bad for the donor.
Right.
It's the right size.
Recipient,
Yeah. If you put a small kidney in a big donor, then in a big recipient, that's a big.
Yes, larger volume is better, but the young kidneys are better. But this is not related to live donor kidneys. But I'm wondering if pediatric kidneys, which are young but smaller. Yeah,
but it depends on the.
If there's any data or
the en-bloc kidneys, it depends on the age of the donor, I think, to when they can hypertrophy to the point. I don't know, I don't have an answer to that.
I'm wondering if hypertrophy in the younger pediatric group is not as deleterious to the kidney as in a small.
I don't know the age. The only thing I know about the kids is that you reach your highest kidney function level ever possible when you reach the age of 2. Based on adjustment for body surface area. That's the best you can get. And then you will stable all the way to the early 20s, and then starts to decline, whatever you want to call it, if you're just for body surface area as you get older. I don't know the histology of the pediatric kidneys. Yeah.
Is there a recipient that's just too big? Like if I have a guy who's 6'5"
Yeah.
and 300 pounds or 340 pounds, his BMI is 35.
Yeah.
Okay. I always tell them, lose weight because
Yeah.
your kidney's going to work better if it's in a smaller body. When you get
Yeah.
one kidney. Is there a size that you just put thinking one kidney in is just
No, I think these are all, well, actually, yes, there's a paper in which they suggested that the kidney size is like 150 cubic centimeters per 1.73 meters square. Less than that is not good. But it's all hypothetical. These are just concepts. Donors, the recipients tend to have one donor. You go for it. And it's always good to tell them to lose weight because you minimize hypertrophy of the kidney. Basically, what I tell them, this is like your car. You are a Honda Civic, or you are a 4 Explorer. Now your engine is gone. So you can get, the half of the engine of F-150, which is a big truck you put in the Honda Civic, is going to take you at this speed, or vice versa. It can both go at 60 miles per hour. One is going to go at 4,000 RPMs, and one is going at 2,000 RPM. In the long term, the one that's going at 2,000 RPM is going to last longer. And on top of that, if you put a trailer in the back and you add another X number of pounds, you are running out the engine at 5,000 RPM, both go at 60 miles per hour. One day, this one is going to give up, like it happens to any car that you overload. So it's the same concept. Now, they only have one opportunity, and that's what you go for. But I think it's good to know so you can advise them better and put this type of analogies, and then they understand why losing weight is a big thing, because you're overworking the kidney. That's what happened in hypertension and obesity. You get secondary FSGS from hyperfiltration. Initially you compensate, and eventually then the drop